Welcome to our series on laboratory testing and how that relates to evaluating hormone health, and we're going to try to help you navigate through some of the more difficult topics with respect to hormones, hormonal supplementation, and associated laboratory tests. And today we're going to try to tackle a topic that's particularly challenging in terms of just trying to understand what we should be expecting from laboratory tests, and that is when we're using transdermal hormones or hormonal creams or gels. So transdermal hormones are unique, that is for sure. When we're looking at blood hormone levels, for example, and hormones are given by way of vaginal, sublingual, oral, these different routes of administration, the blood levels tend to go up in proportion to the dose, and that makes a lot of sense. But when we give transdermal gels, transdermal creams, we don't see this in a way that's intuitive and makes a lot of sense. And one thing you'll find that's, quite frankly, the first time you see is quite shocking, is you get dramatically different results depending on where you go looking for the hormone. So if you're looking for hormone in a classic blood test or in urine testing, you see a very small increase. And as the doses go up, you often don't see the type of increase that you expect to see given the dosing. Simultaneously, if those same people are looking at salivary measurements, you get astronomically high increases in saliva, and it creates this disconnect in terms of what's actually going on with these patients at the tissue level, and that's really where the questions start to creep up as far as what we really should be doing with these patients and how we should be following or not following different lab values when they're telling a completely different story for the same scenario. So let's look at a particular scenario. So here's a case where the researchers are giving estradiol and progesterone topically to women. They're putting it on the breast, directly on the breast, and these women are scheduled to have breast biopsies, so then they're trying to ask the question, how much of that hormone got into the breast tissue? And what you can see is when they're looking at, for example, progesterone, and they're looking in the placebo group, so these women don't have any hormone, haven't been given any hormone, the level is 0.6, so that's relatively low. And when they give women progesterone, I believe in this case it was a gel, you can see that there is a 100-fold increase in the amount of progesterone at the tissue level. So that's pretty significant. But if we look in the blood levels, you can see that progesterone plasma or blood levels were consistently less than 1 nanogram per milliliter. Now, if these women were premenopausal women, or we were shooting for premenopausal levels, we would definitely be above 5, hopefully above 10, and potentially as high as 20. So these levels represent really baseline levels, even though the tissue levels are quite high. So what we can see in a different study where they're looking at, in this case it was a larger study, but this is just 2 particular individuals, you can see with the transdermal progesterone that the levels in blood with these 2 patients never really get very high at all. Again, as with the other study, they said less than 1, and these are, again, less than 1. You can see 1 up here at the top, and these are significantly less than that, which is really about 1/10 of what a young, healthy female would show. Now, concurrently, they're measuring saliva levels. And if you look at saliva, typically when we're not supplementing, a premenopausal woman is going to be around 100, maybe 200. In this case, that'd be picograms per milliliter. And these women both show actually astronomically high values, the red showing 10 times a young, healthy female level, and the blue showing 100 times a young, healthy female level. So again, we have this disconnect of serum values that don't go up very high at all, and then saliva values that are astronomically high, which is a very confusing situation. So what's going on? Saliva values are going way up. Tissue close to the application site we saw was going way up. Remember, in that study, they put the hormone on the breast. They saw hormones in the breast, but they didn't look anywhere else. So we don't know yet if we're getting systemic progesterone with that application, or if it's just more of a local event. But also, serum or urine values in either of these cases go up just a little, if at all. So one explanation for this, and probably maybe your first explanation, is, well, perhaps since saliva is free hormone, and in blood you're looking at free plus the protein bound for total hormone, maybe it's just the free levels that increase. And so we can look at that in testosterone, in that here are men taking transdermal testosterone, and you can see that over the course of 30, 60, 90 days, they're quite elevated for testosterone, not nearly as high as you'd be with salivary testing, but you do get a significant increase. These researchers are also looking at free testosterone levels, and you can see here you get a pretty similar increase, and if you look at the ratio of free hormone, you can see that it's about 2%, which is consistent with the literature, and after 90 days on this hormone, remember at which point their salivary levels are going to be 1,500% increased or even more, there's no increase. So that doesn't explain why the saliva gland would get more hormone than you'd see in serum or in urine. So let's change directions just for a little bit, and instead of looking at the saliva gland as a testing modality, let's look at it as a surrogate. The saliva gland is a particular tissue, and so when we take topical hormones, transdermal hormones, let's look at this question. When we move the hormone around on the body and it gets closer and further away from the saliva gland, from the tissue, what do the saliva levels look like? And you can see you get a pretty, it looks like a slightly dramatic trend from the clavicle area down to the forearm and the abdomen, buttocks. But when you look at this, this is an exponential scale. It's a logarithmic scale. So this is actually an enormous change. As you're getting very close to the saliva gland, you're getting almost 100 times more testosterone in the saliva. So that tells us that we may have a local diffusion of sorts at play here as opposed to systemic circulation of this hormone, and this really presents a challenge for using saliva testing because you're introducing a variable here that's not controlled from patient to patient and the types of ranges and target values that you're looking for, and since it is an exponential change as you're moving the hormone around, that really is going to present a challenge in terms of using this to monitor hormones. Now if we look at this study, what they did is they took radioactive progesterone and they put it on rats, and then they went and found where that radioactive progesterone went, and they put the progesterone on the abdomen, and you can see that in the uterus and the lungs and the liver and the kidney, you're getting a good dose of progesterone, right? So, but again, these organs are very close to the site of application, so we still really haven't established if there's systemic progesterone in all tissue. We can see here the saliva gland is represented a little bit less than some of these, and note the saliva gland's a little bit further away, actually significantly further away than what these sites are. So some interesting data. We do note that urine and plasma have significantly less progesterone than do any of these tissues. So one thing I think we can say is that the salivary increase does not represent systemic exposure. Now how do we know that? If topical progesterone is really getting into all tissue, it has to go somewhere. It's not in the venous blood. Very little progesterone or any of the metabolites increase in urine, and yet we're looking at 100-fold increase in saliva. So if we look at progesterone metabolism, here's progesterone. Now, in the body, in the liver, in the tissue, you're going to have these enzymes that are active. Some of them you'll recognize, 5-alpha reductase you probably recognize, but what you do is you create all of these metabolites. Right, so we can look at 3 on this side. These metabolites happen to be anti-proliferative, which was the subject of this study. The metabolites over here, there's actually an intermediate here, and then we get all of these different metabolites, and those have actually been measured following topical progesterone. Remember at which point the salivary levels are sky high, and none of those increase with even as much as 100 milligrams of topical progesterone. So again, if it's really getting into all of these tissues, you should be making some of these metabolites, and you really don't find them in substantial levels, which makes one think, maybe it is more of a local effect or for specific tissue that have a mechanism of getting the topical progesterone, whereas potentially all tissue do not. Here's one explanation. It's not mine, but I thought it was interesting for consideration. A portion of the hormones measured in saliva after topical application might be getting there by traveling over or across the body surface via shallow subdermal lymphatics or through subcutaneous fat. Now, if that was actually happening, a portion of it would never see systemic circulation, and you'd have this type of a model where you have the application site here on the skin, and a very small portion, it would seem, of the hormone is getting into the blood circulation. And potentially, in some cases, especially if you're close to the saliva gland, a high degree of it is traveling by a different mechanism, and here you can see the saliva gland here. If this type of model is actually correct, it would explain the difference in saliva values relative to blood values and urine values, and what you would expect to see is that the closer you got to the saliva gland, the higher the values would be. And of course, that's what we've shown, that that's actually the case. So that's an interesting model to try to explain what's going on. So let's move out of the theoretical and move more into the clinical side of things to see if that helps clear it up. So with testosterone, what can we look at clinically? Well, we can look at what happens to luteinizing hormone, what happens to muscle mass. With progesterone, we can look at the endometrium. With estrogen, we can look at hot flashes or bone mineral density to see the effectiveness of the hormone. So with testosterone, when men who are hypogonadal take a 100 milligram weekly injection of testosterone, it suppresses LH entirely. So LH is a feedback mechanism. If your body thinks it has too much hormone, you're not going to produce your own, and so you don't need any LH. And it will go all the way to zero. And a 100 milligram weekly injection is not an uncommon dose, but it's enough testosterone that it pushes LH all the way down. Now, with saliva testing and 50 milligrams of transdermal daily testosterone, saliva levels go up 1,500% or even more. Serum or urine values go up modestly, maybe 50%. So what happens to LH with 50 milligrams of transdermal? Because that can kind of give us a window into which one better represents what's going on systemically. So we can see with 50 milligrams of it partially suppresses LH. So these are hypogonadal men. So this 0 point is your baseline, but this is an elevated LH because, again, these are hypogonadal men that are testosterone deficient, and this is 50 milligrams of topical testosterone gel. If men take 100, they end up down here. But what you can see is that what it does is it drops these hypogonadal men right into the reference range for LH. So it suppresses it from an elevated level to a normal level of LH, but it doesn't take the LH all the way down as you would expect if you were systemically getting too much hormone. You can see here from a study where they did testosterone injections that these men, a couple different subgroups, I think this group over on the left was men who were overweight, and then the group on the right, more fit men. But what you can see is in either group, it eventually drove the LH all the way to zero because you're telling the body, I'm getting too much testosterone. And what you can see is with 50 milligrams of transdermal testosterone, the saliva levels go up dramatically. Serum or urine go up modestly. And which is right? Well, the LH suppression would imply that the modest dose, there's really agreement more there with the serum and the urine testing and the LH suppression. But we do find something very profound and something that is definitely worth noting if you're not familiar with saliva testing, is that it does tell us that some tissue do get a lot more hormone than others. So with progesterone, we can look and we can see from the studies we've already shown that we do get increased tissue levels close to the site of application. Saliva, again, increases exponentially. The urine and serum levels don't increase even as much as they do for testosterone. There's almost no movement with even 60 milligrams of topical progesterone. Now, the studies on the endometrium are somewhat conflicting. Leonetti's study found a dose-dependent protective role of progesterone when there's concurrent estrogen. This was a pretty small study. His study was also fairly small, a little bit more thorough, but they found there was no protection from the topical progesterone when estrogen was also given. So does it protect the endometrium? We just can't say that it does because we don't know. And it may well be that it's dependent on where exactly you're putting the progesterone. So just a caution about saliva. There's, again, a profound message in saliva testing with transdermal hormones that it shows that there's a lot more hormone going to certain places in the body than in others, but it really fails the test when you want to examine it as a tool for monitoring hormone levels on therapy because the increase in saliva is not due to its reflection of free or bioavailable fraction of hormone. The data just doesn't support that conclusion, and yet that's what a lot of people assume explains these discrepancies between saliva and serum or urine. And there really are just too many variables for this to be a valuable tool. You have various qualities within the marketplace in terms of the lab values, but that's something you can control by simply working with a lab that really knows how to test these things well. But when you move beyond that, you have variables that you just can't control. The sample-to-sample variability is really high. You've got variability depending on the location of the hormone, the base that it's put in, the patient's body composition in terms of how much body fat you've got to get through there, the timing, and then there is a very real contamination potential. The hormone supplements are about 1 billion times higher than what you find in saliva, so it's very easy for patients to get astronomically high values, not because they're real values, but because of a contamination from the supplement actually getting into the saliva. So again, this data shows one variable that simply is difficult to overcome because you really have exponentially different values depending on where you're putting the saliva, or the hormone rather. Now that could be controlled. You could control it and say, okay, everybody's going to put the hormone in the same place all the time, and then we're going to use saliva testing, but really when you look further at the data, it still doesn't support its use. Typically when people are looking in saliva, they're testing at 12 or 24 hours or somewhere in between post-application of the hormone. And if you look at this study here, this is a particular individual who's taking the same dose of testosterone at 2 separate times and using 2 different bases. And what you can see is if you test at 24 hours, you get about the same value. If you test at 12 hours, boy, they're really close. But what goes on between the application here and those time points is dramatically different. These time points here that look like they're all the same is because I actually brought those down to 700. Some of these go up to as high as more than several thousand, but you get this monstrous wave of testosterone in the saliva gland, at least, with one base, and then with another base that the testosterone is put in, you get a very small increase, and it just creates variability that you just simply can't control for, and so it's just really not going to tell you the information that you think it is when you're using that to monitor hormone. So all this is really interesting. I think there's a lot that's still left to be uncovered, but when you get down to clinical practice, what should we do with topical hormones? And I think for some hormones, you may want to look at a different route of administration so there's just more clarity in what you're doing. With respect to progesterone and the endometrium, if you're going to give estrogen by a different route of administration, if you give oral estrogen, for example, you have systemic estrogen. And I think you can fairly safely say that you don't have systemic progesterone when you give it topically. So if you're mix matching your routes of administration there, you may not be protecting the patient like you think you are. And if you want to protect them, you may need to put the progesterone near the site of action in terms of where you want to protect them, whether it's the breast or the endometrium. And you may actually need to check the endometrium for excessive proliferation with ultrasound or whatever. So with testosterone, I don't want to get into too much detail here, but it really, you might have to reconsider the route of administration given the state of the data and, the fact that testosterone, putting it on transdermally, there is a high chance of transference to other people, and so with testosterone, you may want to just consider another route of administration. But if you're looking at testosterone, you're probably not going to want to follow it with salivary values, and you're probably going to consider blood values and urine values to be at least to some degree an underestimation of what's going on. So with estrogen, it's interesting. There could actually be some benefit to this lack of systemic exposure. I mean, it's possible that you get enough hormone going to the right places that you're getting better symptom control without necessarily getting estrogen everywhere. And so you might want to be cautious where your patients are putting it and keep it away from tissue that's estrogen sensitive with respect to cancer risk. The studies from pharmaceutical products are very interesting. They show that with 0.25 milligrams of topical estradiol, you get improvement of symptoms. And you need to be careful with symptoms in terms of anecdotal evidence, because what the pharmaceutical studies also show is that half of the effect of a high-dose topical estradiol is actually due to the placebo. So when they compare people without hormone to the placebo to the group with hormone, a very significant amount of the reduction in symptoms is actually due to the placebo. So when you're giving very low doses, say 0.05, 0.1 milligrams, you need to be thinking about that part of what you're seeing in your patients may actually be a placebo effect and not actually from the hormone. But at 0.25 milligrams, they start to see this divergent from placebo, where you really do get clinical improvement in terms of the symptoms, but you're not going to get any increase at those levels in serum or urine, whereas with saliva, the levels in saliva will increase even with a dose of 0.05 and 0.1. So what about lab testing? With topical progesterone, I really don't think there's any value in lab testing. The saliva values are simply too variable based on numerous variables that you can't control. And the urine and serum values are very predictable. They're not going to go up unless you use way more hormone than most people are comfortable using. With testosterone and estrogen, if you're going to use urine or serum, you want to use pretty conservative values in terms of what you're really shooting for. But urine testing is nice because you can look at those metabolism patterns and look at how much DHT are we making out of the testosterone, and maybe the 2,4,16 hydroxy estrogens, and how those might relate to potential breast cancer risk and things of those sort. And with DHEA, I think urine testing is really nice because you can look at a more complete assessment, because you're not really wanting to look necessarily at DHEA. You want to know how much testosterone am I making out of that, how much estrogen am I making out of that, and so measuring downstream metabolites might actually be more important than DHEA itself. So you can see a little excerpt from our laboratory test where, if a patient's taking DHEA, then you're going to want to know how much of this is going down to testosterone or DHT, and then how much of that is then being converted into estrogens and some of the other hormones. So it is really important to note, you do not, with topical hormones, want to chase lab values, and that comes in two flavors, really. Practitioners who chase young, healthy levels of, for example, progesterone and estrogen with transdermal products, and looking at, say, a serum estrogen, you're going to have to give way more estrogen than is needed clinically to push those values to young, healthy values that match up with, say, premenopausal levels. You really want to be careful about that. At the same point, when you get these highly variable saliva values, if you're going to tinker with the dosage and trying to get it into some somewhat arbitrary range, that's really not an effective strategy either, because the values are going to change so much with some of these variables that are at play. So the mystery of transdermal hormones, hopefully we've unwrapped that mystery a little bit for you, but you're probably left, as I am, still with some questions, because there really are questions left to answer. But if you're not confused about topical hormones, then you're probably not paying attention, because we're really just not there yet in terms of understanding the model, in terms of how the hormone is delivered to the tissue, and so there's a lot more to learn. So if you have any questions about this topic, feel free to email info@urinehormones.com, or you can visit our website at urinehormones.com.